Pleasure to introduce today's Grand Round speaker, Priya Verghese, Assistant Professor in the Division of Pediatric Nephrology. Priya received her medical training at Kasturba Medical College in India and has done 2 pediatric residencies, one at Madras Medical College and Malhar Hospital in Chennai, India, and another at University of Illinois at Chicago. Priya was a Pediatric Nephrology Fellow at University of Washington, where she also did a fellowship in pediatric transplantation and received a Master's of Public Health. Priya joined our faculty in 2009 and became Medical Director of Pediatric Kidney Transplantation in 2012. Her major interests are improving transplant outcomes, particularly reducing the burden of viral disease after pediatric transplantation. And with that, I'll let Priya take over.
Thank you, Cliff. So I've had the privilege of giving ground rounds here before, and as Cliff mentioned, this is a particular area that I'm fascinated by. So I did the best I could to make sure there wasn't much repeat information. And this time it's particularly exciting for me because I get to present some of the research that I've been doing here since I started. So I have no disclosures, and my objectives are to describe the evolution of renal failure therapeutic modalities, and then talk a little bit about the balance of immunosuppression and prevention of rejection and infection, and then talk about some novel approaches that we've done here to prevent and treat these post-transplant infections. And I know that the majority of you in this room are not nephrologists, so I'm hoping to keep it really interesting and keep any of you from Facebooking, sleeping, crying, and I'm definitely hoping none of you are going to be doing this. So what happens if your kidneys don't work? Before dialysis, before transplant, we still had renal failure. What happened to those patients? Well, bad things happened to those patients, unfortunately, because the kidney is responsible for fluid and electrolyte balance. The kidney is responsible for bone health. The kidney is critical in maintaining your hemoglobin. The kidney is really a very, very important organ. So if you didn't have a way to treat kidney failure, ultimately it meant death. And it didn't matter how many opinions or how many physicians you sought, there was really nothing for it. And that's what happened before the advent of dialysis and transplant. Patients died if their kidneys failed. The concept of dialysis and treating patients that had kidney disease is an old one. Actually, in 19 AD, there are reports of Roman centurions with renal failure going to bathhouses to steam out uremic toxins. I don't know how effective that was, but we've come a long way since then. And in Europe and in America, when modern dialysis first began, as you can see, the machines are really unwieldy. There's lots of wires. And what you can't see in this picture is the dialysate. The dialysate that we today run at 600 cc's per minute had to be physically brought in giant barrels. And there are all sorts of stories and anecdotes of people wheeling in these barrels full of dialysate, and as they entered into elevators, having little accidents and spills, which is not difficult to imagine. The worst part of all was that initially when dialysis started, you needed your own blood pressure to pump your blood through the dialysis machine. And for those of you that have worked with us, you don't always consult us on patients that have great blood pressure. And so for a lot of patients, even if dialysis was an option, they needed to be able to do the dialysis for themselves. So as we started to learn more and more about how to effectively do dialysis, there was the creation of blood pumps, and we also started to realize that we needed access. So this is a catheter. As you can see, there's a loop from artery to vein. The entire thing is exposed outside the patient's arm. I don't know about you guys, but it might be a little uncomfortable to walk around with all your blood whizzing through a tube that's on your forearm. So far from perfect, huge infection risk, huge exsanguination risk. And unfortunately, PD was not much better. Peritoneal dialysis, which is through the abdominal cavity, also had these unwieldy tubes. Here's a 40-liter glass jar, which is how the peritoneal dialysate was brought to the patient's bedside. So right now, we train patients to do PD at home. This could have been a little complicated to do at home if you had to bring in a 40-liter glass jar of dialysate every night. The worst part of all was that not every hospital was doing dialysis. Dialysis was offered in Boston and in Seattle, and that was it. So what happened to these masses of people with renal failure? How did they decide who got to do dialysis and who didn't? Well, they set up this panel. It was a panel of anonymous people. Some were priests, some were medical people, some were family people. And this anonymous panel had to read through letters and stories and decide which patients got to get dialysis and which patients had to go home to die. Was it the 10-year-old boy that had his whole life ahead of him, or the 28-year-old mother of 3, or the 35-year-old breadwinning father of the family? It was a tremendous burden. And the stories that I heard from Seattle, where I did my training, were quite dismal. Apparently, some of the people that served on these panels had severe depression, and suicide was common because it was an enormous stress for them to have to make these type of decisions. So that's where we come to our modern day dialysis. And we've done really, really well. So some of you might know this young man. This patient is Maxim, and he's a 2-year-old patient of ours with hemolytic uremic syndrome who's on chronic dialysis. Look at how comfortable he is as dialysis is being initiated. Look at the size of the machine. Look at the size of the dialyzer. Very small. And above all, he's very comfortable and happy as he gets on dialysis. He spends most of his time playing with trains and watching TV as he undergoes dialysis. So we've done very, very well. So you might be wondering why I'm talking about this in a transplant talk. Well, the relevance is that, unfortunately, despite all these advances, it's still not perfect. It's far from perfect. If you look at deaths per 1,000 patient years at risk, the hemodialysis and peritoneal dialysis patients have a very high risk of mortality. And the more years you spend on dialysis, the higher your mortality. In fact, in the adult population, patients are dying on the transplant list as they wait for a transplant. So dialysis is not perfect. And so we knew that. And for those of you who are thinking dirty thoughts, this is supposed to be dialysis is a big pain in the arm because of the fistula and the catheter. So what that led to was the introduction of kidney transplantation. This is how the birth of kidney transplantation occurred. It was clear that dialysis was not good enough. Well, the field of kidney transplantation has gone through a lot of preparation before we were ready to actually do the transplant. In 1667, Jean Denis transfused sheep blood into a 15-year-old boy, and the boy died. And for over 150 years, no one was willing to attempt a blood transfusion again. 150 years later, James Blundell decided, well, the problem was that it was sheep blood. Let's try human-to-human blood transfusion. The patient died. It was only when we discovered blood grouping that we could even fantasize about the thought of doing kidney transplantation. So the identification of blood groups and blood transfusion was a critical step towards kidney transplantation. This is a pretty scary picture of a man getting his leg amputated. His physicians are wearing their street clothes. They have no gloves on. There's a gentleman at the head of the bed because there was no anesthesia. You got a swig of alcohol or a knock on your head to concuss you if you started wriggling too much. I don't know how many of you have met Dr. Chinnakotla, our transplant surgeon. He's not the kind of guy to knock out a kid or give him a swig of alcohol before we do transplant. It's just not the way we do things. So we needed to develop anesthetic techniques, and we needed to have this concept of antisepsis, which is what Joseph Lister brought to the field of medicine. And finally, we had to perfect the art of vascular anastomosis. Having set the stage, though, the kidney was really a perfect organ to start with as an organ transplantation. Most of us have two of them. We don't need two. We could give away one. And the kidney is a simple organ in that it has one artery, one vein, and one ureter that need to be anastomosed in most cases. So we also thought that this was a great way to start because the kidney makes urine, which is a useful way to appreciate how well your organ is working. And so we did. We started kidney transplantation. The first transplants were animal autografts, and then we evolved to animal allografts. And then in 1906, Matthew Jabole transplanted 2 kidneys into the arm of dying patients. Unfortunately, the kidneys failed, but it was the first attempts at this concept of human kidney transplantation. And then in 1950, a 44-year-old woman, Ruth Tucker, had ADPKD and renal failure and received a kidney transplant. She had this graft for about 10 months. But why I hesitate to call her the first transplant is because when the graft was removed 10 months later, she continued to live for 5 more years. So it's almost like that kidney transplant was just bridging her through acute renal failure. And then, of course, there is Voronoi in Russia, who had 6 transplants in the 1930s. Details of those are scarce. I think really the first modern attempts of kidney transplantation were the Richard and Ronald Herrick twins. In 1951 to 53 in Boston, they did their initial transplant program. They had 9 donors, and all 9 failed. One lived a record 6 months, but most of them, all of them died. And so really the Herrick twins was this phenomenal breakthrough in our field. 2 days before Christmas in 1954, these identical twins underwent surgery. The brother who gave the kidney actually just died 5 years ago. And he was celebrated in all the transplant journals because he really changed our field. And his brother lived for 8 long years after that, which was huge in those days. And by the mid-1970s, 35 twin-to-twin transplants had been done with really good results. And the surgeon that did this transplant got the Nobel Prize for Medicine. So this was just an enormous breakthrough in our field. So having started the field, we, of course, have not stayed stagnant. The field has continued to grow exponentially. Our initial transplant failure was because of our lack of knowledge of the immune system. And as we learned more, our immunosuppression evolved. I'm not going to spend a lot of time on this slide because I think I've shown this slide before, but I think it's compelling of our journey through transplantation. So when we initially started transplantation, patients received total body irradiation and splenectomy. And they didn't reject, they died of overwhelming sepsis. And then came azathioprine and steroids and induction immunosuppression with thymoglobulin and Cellcept and tacrolimus. And now the list of drugs that we have open to us is endless. And you know what? It's been fantastic. Our 3-year survival in kids getting either a living donor, which is in pink, or a deceased donor, which is in yellow, is fantastic. It's over 90% across the boards, regardless of how old the patient is. So we're really doing very, very well. And if you look at our graft rejection rates, this is data from the North American Pediatric Renal Transplant Collaborative Society, and you can see that in 1987, 71% of patients would have at least 1 rejection, and this has come all the way down to 13% in 2007 to 2010. So quite simply, our field is exploding, and we're making tremendous progress, and we're going in the right direction, so we can just continue along this journey, and we're done. Well, sadly not, because it came at a price. As our field evolved away from rejection, what happened is we paid for it by increasing the infection risk in our patients. infections today are the cause of death in a third of our transplant patients with a functioning graft. And infections not only lead to infectious related complications, but they can also cause malignancies. Today in the US, the majority of hospitalizations after kidney transplantation are not due to graft dysfunction, they're due to infections. And this is particularly compelling in the pediatric patients. This purple line is pediatric transplant recipients, and you can see their admissions per 1,000 patient years at risk is enormous. If you look at the cause of death following index renal transplantation, once again you find viral, bacterial, unspecified infections, malignancies due to infections, tremendous amount of mortality related to these infections. So unfortunately, we did really well with protecting the kidney, but we paid a price with the patient. So that's what brings me to discuss my research. It was clear to me when I started that there was lots of amazing people doing amazing work with immunosuppressive drugs. But what was not clear was that in our kids, we all knew and we were struggling with infections, but we weren't trying new things or not enough new things. So I've been working with Hank Balfour's lab across the river. These are two of our amazing lab people, Max and Jen. And this is a little EBV virus. It looks very benign as a stuffed toy, far from it. We'll talk a little bit more about that. So viral infections in particular, I find extremely interesting. Bacteria and fungi have really bad consequences after transplant. But there's antibiotics and antifungals, and yes, they don't always work, and Bazak, don't be upset, but it's not as exciting as viruses. Viruses frequently don't have appropriate therapies. We don't often know where they've come from, and some of the most interesting viruses to me are the viruses that all of us could get and would do nothing to us, but then you get an immunocompromised patient and all hell breaks loose. So some of these viruses that I've been studying are the cytomegalovirus, the Epstein-Barr virus, and the BK virus. And as I said earlier, these viruses, in addition to infection, put the transplant recipient's graft at risk, their lives at risk, and they're at risk for malignancies. And these infections are a huge problem in kids as compared to adults. And the reason is simple. The kids have more often never seen this virus before. They get transplanted, and for the first time they're being exposed to the virus when they're already immunosuppressed and they have no memory response to these viruses. So CMV continues to be one of the most common pathogens in transplant. The cytomegalovirus is a virus that in the general population may do nothing more than malice, upper respiratory tract infection, but in an immunocompromised transplant patient can cause severe pneumonia. In fact, when the field of transplant was first making its journey through, many of the transplant recipients were in ICUs on ventilators for CMV pneumonia. We've done better. We now have antiviral drugs that work against CMV, but despite our antiviral drugs, it continues to be the most common pathogen in kidney transplant. CMV can also lead to CMV retinitis in our immunocompromised patients, so this was a virus that I thought we should really start looking at. Epstein-Barr virus is also a fascinating virus. All of us as pediatricians in this room know about Epstein-Barr virus, also called the infectious mononucleosis virus or the kissing disease virus. It can cause a cough, a cold, a sore throat, hepatosplenomegaly in the healthy population. So not benign, but not life-threatening in most cases. And in the healthy population, the thought is that this is caused by deep kissing. So Professor Balfour has done work looking at freshman students here at the university, and he found the greatest risk factor for developing EBV in your freshman year was deep kissing, not sexual activity, it was the kissing. And so we wanted to find out exactly what we could do about this virus in our population. Now, unlike in the general population, our kids are not getting their virus from kissing, we think. We think they're getting their infection via the organ. And one of the reasons we have this feeling is because there are several reports through the last few years that have described that the highest risk patients or transplant recipients for these infections are ones where the donor was positive for the virus and the recipient negative. So while we've never quite identified which cell the viruses are coming through to, we know quite clearly that the viruses in transplant recipients are coming with the organ. So we thought, well, in AIDS patients, when we started to treat infected mothers, the rate of HIV infection in the newborns just dropped. So we thought, why can't we do the same thing in transplant? Why not reduce the transmission of the virus to the recipient? Let's not look at just the recipient after transplant. Let's stop the virus from coming through at all. So the next question was, what were we going to use? And currently, in our community, the drug that's most commonly used for treatment of CMV disease is valganciclovir. This drug was given birth to in the 1990s, and it really changed the field of transplantation because now CMV that was killing patients and preventing optimal use of immunosuppression could be managed with this drug. Now, as I said, it's not a perfect drug. CMV breakthrough infections are occurring. We are seeing CMV resistance. But this was the only drug we really thought had been proven to work against CMV. Now, we do have to admit we weren't sure what valganciclovir would do against EBV. It's never been directly studied. Anecdotally, most transplant programs across the U.S. do report reduced EBV rates following the institution and implementation of valganciclovir prophylaxis, but many changes happened at the same time. So it's hard for us to, with conclusive confidence, state that valganciclovir has anti-EBV activity. But nevertheless, we decided to use valganciclovir. We decided to do 14 days of therapy in all living donors that were going to give their kidney to their recipients. And we gave these living donors valganciclovir for 14 days prior to the transplant. And then we observed the recipients for viral replication after transplant and viral disease after transplant. As with any pediatric single-center study, the numbers were small, but the study was really, really fun to do. We actually had patients that were calling us and asking us, please, can you make sure that my child gets the drug and not the placebo? We had adult patients calling and saying, is there any way that we could enroll in your trial? There was so much awareness of the risks of these infections after transplant. Parents and patients really wanted to be in it. But unfortunately, funding, et cetera, we had to restrict it to high-risk patients. We enrolled 19 eligible living donor recipient, we approached 19 eligible living donor recipient pairs. One refused to consent. And interestingly, it was the recipient that refused to consent because she felt she did not want to put her donor through the trauma of taking 14 days of therapy. So once again, it was not that the donor felt that they didn't want to participate or take the med. So we finally had 18 pairs. One transplant was indefinitely postponed. We had to eliminate them. So finally, we ended up with 17 donor-recipient pairs. 10 of them were randomized to placebo and 7 to valganciclovir. We were double-blinded, so we had absolutely no idea who was getting the Valgan and who was getting the placebo. Both drugs were encapsulated in another capsule. And the donor side effect reports were fantastic. There were only 2 participants that reported a side effect, mild headache, and 1 patient stated itching, and both were in the placebo group. So really very well tolerated. The compliance was amazing. 100% of patients returned study diaries and came in for pill counts, and the number of missed doses was minimal in both groups. And mind you, this is not unusual because if you think about it, these are kidney donors that are very motivated. They're lopping out a kidney to give it to someone else. They're already above averagely amazing people. So of course, their enrollment in the study and their performance during the study was really, really amazing. And here are our results. Of our 17 pairs, we had 8 viremias, and 5 of them were in the placebo and 3 in the valganciclovir. So the numbers were so small, we could not comment on significance. But what was really compelling is we only had two diseases. One was CMV disease, and one was an EBV positive PTLD in a supraclavicular lymph node, and both occurred in the placebo. We had absolutely no disease in any of the recipients where donors had been treated with antiviral drug. So we thought, let's not get too excited. What if the EBV that caused the PTLD was from the community and not the donor? So what we did was we took the supraclavicular lymph node, we took curls from the lymph node, and we isolated the EBV. And we went back to the donor salivary wash and isolated the EBV. And we compared both strains by LMP1 sequence variation. And I don't know how well this is projecting, but if you look here, they are identical everywhere, just completely identical. And so from other publications, based on this sequence analysis, we can be conservatively 99.36% certain that the EBV that caused this PTLD came from that patient's donor. So the conclusions of this study was that our numbers were small, yes, but they're very suggestive that if we treat donors, we can reduce the burden of virus coming through the kidney so that with post-transplant recipient prophylaxis, recipients can be more effective in controlling low-level replication. So while there might be viremia, disease would be less likely. And this needs to be studied in a larger setting. Now, one of the big drawbacks of this study was that it had to be living donors. So we didn't talk about deceased donor recipients. We didn't talk about post-transplant viral prophylaxis. We weren't looking at other viruses like the BK virus. So we wanted to do more. This wasn't enough. So we did a survey. We sent a survey to the last 50 patients that had been transplanted at the university. And we asked them for basic knowledge on viruses and what was being done for them post-transplant. And this was to adults and peds, and the respondents were 70% peds and 30% adults, once again showing how amazing pediatrics is. But 92% of the patients were on valganciclovir after transplant, and this is to be expected. This is our standard of care. A third of patients reported that they were having side effects to the valganciclovir. Now, my donors said that they had breezed through without any side effects to the Valgan. But it's important to remember that these are transplant recipients that are on other medications where side effects can be combined. So valganciclovir is infamous for marrow suppression and leukopenia, and our transplant recipients are also getting Cellcept or MMF, which also causes marrow suppression. So again, it's not surprising that donors tolerated the drug so well and recipients, a third of them are complaining of side effects. So we asked our patients whether they would be interested in an alternate CMV prophylaxis drug, and 75% said yes. Now, not all of this was because of side effect. It's also because one tablet of valganciclovir is $45 as compared to 50 cents for one tablet of, for example, valacyclovir. So there was a big cost issue there as well. So we went through the literature to try and get an assessment of, are there any other antiviral drugs that we could be using? And in the 1990s, in the New England Journal of Medicine, there was a randomized controlled trial comparing valacyclovir to placebo in preventing CMV after transplant. And Dr. Lowens showed that it worked. Valacyclovir was effective. It did prevent CMV. The problem was CMV was such an enormous problem at that time, and Valgan was just sweeping the market. It had great company representation. So before we knew it, it had become standard of care. So there had not been a comparison of Val-A to Val-G, only Val-A to placebo. Nevertheless, we decided we can't keep complaining about side effects if we don't look at alternate drugs. So I thought this was interesting. This gentleman says, this is the third time I had to replace the clutch. And the other guy says, well, don't blame me, I never use it. So similarly, it was clear that we couldn't keep complaining about the antiviral prophylaxis until we explored our options. So valacyclovir has been shown to be comparable to oral ganciclovir in CMV prevention, but no one's ever looked at it compared to Valgan. until they did. So Dr. Hanna burst my bubble. I had submitted to the IRB to do a head-on-head comparison of Val-A versus Val-G when he came in one morning and said, "Hey, have you seen this paper comparing Val-A to Val-G?" And so I was, of course, heartbroken. I figured, oh my gosh, my study, I should have done it 2 years ago. I knew it. And I was excited to see that the results were exactly as we thought that they would be. The Val-A and the Val-G were very, very effective in preventing CMV disease. Very effective. And the side effects between the two groups, although not significantly different, if you look, you can see quite clearly there was more leukopenia, neutropenia, and neupogen use in the Val-Gan group. And there was more study discontinuation, which again was not significant, 22% versus 10%, but everything was pushing towards Val-Gan being the inferior drug. If you read the fine print, you'll find that Val-Acyclovir was discontinued in one patient because they couldn't take oral drugs. Well, that's not Val-A's fault. In 3 patients because of leukopenia and neutropenia, well, Val-A doesn't cause leukopenia or neutropenia. So I was really excited. I thought, you know what? This is what we hope to find. And I was even more excited when I realized that in this study, they had excluded children. They had hardly any high-risk patients. This was a Czechoslovakian paper, so it had only Czech adults. Their immunosuppression protocol was totally different. And most importantly, they had dosed the Val-Acyclovir 4 times a day. So I don't know about all of you, but there's no way I could take a drug 4 times a day. And with this type of study design, they did no testing to see whether their patients actually took the drug. There was no assessment of levels, nothing. So I'm excited again because I figured, hey, you know what, we can still do the study. And I asked our patients whether they would still be interested in a study given that there's already published data. And again, 77% said yes. And it was the PEDS patients that felt we needed to know. So we set up a patient advisory board and we designed a prospective randomized trial. It's supposed to be a pilot study of just 30 donor-recipient pairs. And what we want to do is after transplant, we're going to randomize them to either get Val-Acyclovir or Val-Ganciclovir. So far, we have enrolled 5 recipients, and we're only aiming for 30. So I actually think I'm going to have preliminary results in about 18 months. My patient advisory board is not thrilled. They think we should be enrolling everyone. I don't have money for it. So we're working on that type of stuff, but very, very exciting stuff. So I'm going to change gears a little bit. And don't worry, this is not how I drive, but this is changing gears. So far, I've talked to you about novel ways that we can prevent transmission of virus via the organ, and I've talked about new antiviral drugs that we can use for prophylaxis. But what if we could prevent a patient from getting infected completely? What if we could vaccinate them? And actually, there is an EBV vaccine being designed, and I'm excited to say that we are one of the sites that they're looking at for running the entire study, looking at this EBV vaccine. If you look at the EBV vaccine compared to the placebo, are the open circles, the dark black circles of the vaccine, you can see that subjects had much less disease with the EBV vaccine. And I would also say it's important to note that these 2 failures happened within a week of the vaccination. So it's plausible that the vaccine didn't occur in time and that it wasn't a vaccine failure, but the immune response had not had enough time to develop. So our first step is to design a study to ensure that it's safe and effective in freshmen here at the university. And if that works well, then our next step is to do a multi-center study in our EBV-naive candidates to see if we can prevent EBV viremia and PTLD after transplant. All right, so I'm going to shift gears one more time. Don't worry, this is the last time. So I'm going to go to the BK virus. The BK virus is a virus that was actually not well known until the last century. And BK is named after the initials of the first patient that was identified with this virus. Again, 70% of you in this room are peeing BK virus on a regular basis, and you didn't need to know that because it's not relevant. It's not going to bother you. It's not going to cause any symptoms. It's not a problem until you immunosuppress the patient. With immunosuppression, this ubiquitous innocent virus becomes very, very nasty. So in kidney transplant recipients, the infection can cause what's called BK nephropathy. And we've actually seen BK nephropathy in other organ transplants, in bone marrow transplant recipients as well, but it's most commonly reported in our kidney transplant recipients. And BK nephropathy is one of our most dreaded infections because once it sets in, graft loss occurs in up to 50% of the patients. It can be a really, really scary virus. So we thought we're focused so much on CMV and EBV. What about BKV? Does BKV come through the donor? If that's the case, then just like we did this donor study for CMV and EBV, can we do something to prevent donor transmission? So the first step was trying to figure out if the BKV really came through with the donor organ. So there were reports that suggested that just like in CMV and EBV, BK was most common in recipients that were seronegative to it and had received an organ from seropositive donors. So we did an NIH-sponsored 5-year prospective study, and what we did was we looked at all donor-recipient shedding of BK virus. And we looked to see whether donors that were shedding BK at the time of transplant increased the risk of BK infection in the recipients. And we were not surprised to find that it did. If your donor had BK detectable in their pee when they donated their kidney, the recipients were probably going to have BK viremia within their first year of transplant. So we think that this is compelling evidence that just like we're doing work for CMV and EBV, we need to be looking at BKV in the donor organ as well. So that's some of the very exciting research that we're doing here. And to conclude, I just wanted to say that through all of these ups and downs, this field has endured and improved. And it's because of nonstop high-quality research being done in the US and in other countries that the field continues to be as exciting as it is. If you look at where we started here at the university, our first transplant was done on June 7th in 1963. And later that same year was our first pediatric transplant here at the university. And since that time, we've done over 1,000 pediatric kidney transplants. In fact, we have done more young child or donor transplants than anyone else in the country. And I think Dr. Chavers did a great grand rounds where she talked about some of our younger transplant recipients. We've also done the first paired exchange in a pediatric patient, which is where two donor-recipient pairs don't match each other, but they exchange. And we're one of the pioneers in the field of encouraging living donor transplantation. And we're doing it well. So if you look again at the North American Pediatric Renal Transplant Collaborative Society report, you'll find this red dotted line are modern-day living donors, and the graft survival is fantastic. The yellow line is deceased donor, and again, so much better than where we came from. So as you can see, our field has really, really endured through a lot of ups and downs, and overall, we have been getting consistently better. So we've made a lot of progress. We continue to struggle with kidney transplant rejection, but really the most important problem we face today is over-immunosuppression and infections. They're the leading cause of hospitalization, morbidity, and mortality after transplant. Viral infections can predispose you to malignancies, and this is particularly relevant in children. And here at the U, we're doing some really fun research to try and see if we can novel methods to prevent these infections with vaccines, better prophylaxis, or preventing donor transmission. And these are my 3 babies. Thank you. John.
Priya, it's Back to the Future Day. And on Back to the Future Day, I wonder if you could comment a little bit on the future. You know, a recent Nature cover story suggested we're not that far, perhaps, from growing kidneys in a dish. And I wonder whether the future of kidney obviously the future of kidney transplantation will be influenced by that, but in what ways, and is it really as close as some people believe?
So I can't give you direct data to answer that question, but I don't think we're close enough. Now, having said that, I got my first email address 15 years ago, and today I don't go anywhere without my iPhone. So I would say nothing is impossible. I would say that every 2 years, the university hosts a national transplant immunosuppression meeting. And they get these world-renowned speakers to come and talk to us about the latest and greatest in the field. And what's striking every 2 years is that the more we learn, the more we know we don't know. So we have patients actually that come and ask us, how close do you think we are to growing a kidney? And I always say, well, let's take it one step at a time. I don't think it's going to happen in this life, but, I have an iPhone that I never walk around without, so, yeah. Bazak. Don't get mad at me for my comment about
John
bacteria.
stole my non-infectious question, so I did have one infection. Did you guys look at the donor virus-specific T-cell transfusions? Are there pre-transplant to donors, although it seems a bit
Yeah, that's
too
such a
aggressive,
fantastic question, and we did not, and I really want to. That's one of our future directions. I actually didn't talk about a lot of other great stuff we're doing. I think that's the direction we should be moving in. And if you look at the journal, the American Journal of Transplantation now, there's more and more papers suggesting that by the time we're finding the virus, it's too late. If we wait for viral replication, we're one step behind. If we look for the T cells, we can actually identify who's at risk for these viral infections and swoop in one step before.
And just as a side note for that, you said the future. I think, in my opinion, it doesn't matter what treatment modality you'll have, an immunosuppressed patient will find a way to get sick.
Yeah.
So I think definitely the future is what John said. Because in theory, if you use the same person's stem cell for that, there will be no immune suppression.
Yeah, the holy grail of transplant is tolerance. What we want to do is get to this point where we can put in a kidney and then withdraw immunosuppression, and the patient treats the kidney as their own. And people have been working on this for years and years and years. We did some work here at the university on donor-specific. Nothing's really reached human arena. Every transplant journal has something about it.
Let's use the patient's own cells. So in theory,
Yes.
I know that my field is stem cell, this cord blood,
Yeah.
so things like that.
Yeah. And the same thing is true for the infections. And we're getting close to that. I think soon we're going to have EBV-specific T cells that we can infuse to attack the EBV. Yeah.
Thank you, Priya. Very nice.
Thanks.
My question is a little bit of a follow-up to what Bazak was asking about, which is, in the absence of having a new kidney that we can generate in a petri dish, are the immunosuppressive regimens that are used, are they very consistent across the United States or globally? And is there an association between particular regimens, and maybe we'll learn at some point that individuals with a certain T cell subtype would do better on one regimen versus the other. So how much of a role does the immunosuppressive regimen play on infection risk?
That's a fantastic question. And the truth is that that is one of the biggest detriments of the field of pediatric kidney transplantation. Everyone is doing it their own way. In fact, today I had a quarterly transplant protocol meeting with some of our group to discuss some of our immunosuppression protocols. And I looked and I presented to our group the national data just to see where the country is going. And you won't believe the variation, not only amongst different centers, but even within center. In our group alone, there's variation in practice. So I think to answer the question of the role that the immunosuppressive drugs play, we need to all unite. So I always talk about the children oncology group because I think it's such a phenomenal concept, and we should so do it in pediatric kidney transplantation. Now, having said that, we all do know that there are certain higher risk immunosuppressive drugs. Tacrolimus, infamous for more BK and more badness. But the problem is, it's kind of like that balance scale I showed you. Tacrolimus also has less rejection. So what we need is this magic blood test that's going to tell us where our immunosuppression is sitting. Right now, what we do is we wait for rejection or infection. It's donor-specific antibodies, viremia. So we're waiting for the balance to tip too far before and we don't have a blood test. We don't have a way to measure each individual patient's immunosuppression. And today, all of us work with protocols, yet each drug is metabolized differently based on your own genetics. So, two of my transplant patients might be getting the same per kilo dose, and yet one patient's levels are through the roof, one patient's levels are great, one patient might have through the roof levels but do fine, the one with, normal levels is rejecting. So we have a lot of work to do, which is what makes it so exciting. Yeah. All right, thank you.